Good morning, everyone. Thank you so much for joining us today. We have Ms. Shereen Idiculla with us, and she'll be talking about oral placement therapy today. And introducing Shereen, ma'am. She is a speech language therapist, feeding therapist, AAC coach, and reflex integration therapist. She has over 20 plus years of rich experience working with children with various language disorders like childhood speech of apraxia, children with cerebral palsy, Down syndrome, and autism. And she's also the creator of Learning Through Rhythmic Movement and the Whole Brain to Speech Protocol. To work with these programs work with neurodevelopment disorders or neurodiversity, and she empowers parents to help their children regulate, connect, interact, communicate, and build pathways to speech. She has collaborated with multidisciplinary teams, including occupational therapists, physical therapists, psychologists, and educators, to create comprehensive and holistic treatment plans. She's also a level 4 oral placement therapist in India. Uh, and she was awarded the Vocational Excellence Award in 2020 by the Rotary Club Bangalore. Thank you so much for being with us, Shereen ma'am.
Thank you for inviting me. It is a pleasure and an honor always to talk about a topic that has been an interest to me for over now be 14 years, I would say. And it's, I think, going to be quite interesting to see how I could put the information across to everybody. And I'm hoping they get the gist of it in this next 1 hour. Questions are always welcome by parents. If you want to ask in between, if you haven't understood something I've said, please feel free to raise a virtual hand and I will try to answer the questions. But we can have a Q&A at the end too, if you want to put it in the chat box or you want to unmute and ask at that point of time. I do hope some of you have questions. Otherwise, it makes it a very boring back and forth interaction if there are no questions. So I always welcome questions. So yeah, today's topic, as Bindu mentioned, is oral placement therapy and what it is. Some parents do know about it. Some parents think that that's what's going to get me to the speech. Ultimately, some parents have not heard about it. So we have a mixed group, and I just thought I'll just try to put some basics in and see how it connects for all of you. So I'm just going to open up the presentation. I'm hoping it's not too long a presentation and I can finish it on time. Oral placement therapy, that's what we're going to kind of look at the agenda. What is it? What's the rationale behind it? Where do we use it? Is it used for everything and anything, or are there specific conditions we use it for? What are the goals? And I want to briefly just touch upon something called the pyramid of learning, because that has helped me personally and professionally to understand how to move ahead with a child's speech language communication. And just giving you a brief about some of the OPT activities that are done. I cannot go into a lot of detail because I don't have enough time to go into a lot of detail, but just briefly to just look at what does it comprise of? What are the kind of things that you do in OPT? Right. And so that's what I'm hoping to cover with all of you today. So what is oral placement therapy? It's a specialized speech therapy technique. It's a muscle training program. Like you have physiotherapy where if a child cannot walk or they have weakness or if you have pain, you take physiotherapy to kind of help the muscles get better in their function or to gain strength. And similarly, this is the simplest way I put it. I'm not sure a lot of people agree with me. It's like physiotherapy for the mouth, where you are working on the muscles of the mouth and working towards a goal. What is the goal? The goal is the two functional things that we do with our mouth: feeding and speech. These are the only two things that we do functionally with our mouth. So this technique is working on a muscle-based program with auditory stimulation, visual stimulation, but tactile stimulation being the added one here, which is different from other oromotor programs, where we combine these three to help the child or the adult or the teenager, whatever age they might be, to improve the movement, the functional movement of their mouth to support speech, speech clarity, speech production, and feeding. It was developed by this lady you see in front of you, Sarah Rosenfeld Johnson, in the late 1980s. She has retired now, but she has created a wonderful program, and there are many trainings that come on OPT every year, almost twice or thrice a year now to India. that help professionals learn what to do, but they even invite parents to learn. It's open to parents, to educators, all professions, because if you know what you can do at home, you can help your child better, and maybe you can help some more children too. So it is a program that is open to everybody. It gets a little technical, but I think even then it is something that you can pick up if you understand the rationale behind it. Now, what is the rationale behind it? Okay, I'm going to give you an example. Now, suppose you have something that goes into your mouth, a food item that goes into your mouth. What's the first thing that we feel? We get that sense of feeling of what it is. That's a tactile feedback, or something just came into my mouth. Now we got to figure out what we need to do about it, right? And that is what makes us move it. Okay, I have got something in my mouth. I can't just keep it there. I've got to move it to my molars to chew it. So that movement is what is the feedback that we get. Okay, I can't just keep it. Let me move it. And that's your kinesthetic feedback that you get, how much you moved it, where you moved it. And then, depending on the texture of the food that you have, whether it's an idli versus a breadstick, you have to figure out, wait, how much pressure do I put to chew this item? Do I put a lot of pressure? Do I put a little pressure? Or just just chew a few times and it's going to be broken down? Or do I just swallow? That's your proprioceptive feedback that you get. And finally, when you look at it, you have a motor plan that you create. Okay, food comes in, goes to the side, chew, 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 how much to chew, swallow. So there's a whole plan that's created. And then when the next food comes in, or you get, again, it's a cycle. Why? Because once you swallow again, you're trying to figure out, are there any particles in there? Do I have to swallow again? Are there more things that I have to do? So all of that whole process is the rationale of OPT, that you get your tactile feedback, which helps you know whether to move, which helps you know how much proprioception to use, which helps you create a motor plan, which again goes back into, okay, have I completed that? Is there more feedback I need to get? Have I completed that? Whether it's a word I have to say, a sentence I have to say, a food that I have to eat. This is the rationale behind it. All right. Okay. So where all can it be used? So I would look at, there is something called oral placement disorder. Now this is defined as conditions where a child is not able to imitate. Look what I'm saying, say what I say, right? Or they're not able to follow specific instructions. Okay, can you close your lips and say, Those are the kind of things that we tell our children. Okay, can you open your mouth and say, ah? Or can you look at me? Can you say, mama? So if a child is not able to imitate that, because that's what imitation is, it's auditory visual, right? We're able to look at somebody and get to it. But what if a child cannot do that? What if they find it difficult to imitate? And that's what Diane Barr and Sarah Rosenfeld Johnson defined as an oral placement disorder. They're not getting those cues for different reasons. So those children or adults or teenagers who seem to have that difficulty, that's where oral placement therapy could help. Right? We also look at it from a function of the muscle function is affected. Is it weak? Okay, that's where it could help. If there's any strength that's affected in the mouth, they don't have good controlled movements in the mouth. Like I'm saying, I want to go and I'm going, oh. If I'm doing that, okay, there's not much stability, not much strength in the jaw, okay, that's where we look at oral placement therapy again. Or if a child has dyspraxia, childhood apraxia of speech, and there's motor planning that's been affected, sequencing that's been affected. So again, it could be one out of these three, it could be two out of the three, it could be all three that are affected also with some children. So that's where what we need to identify and then accordingly put the plan across. So this is in a brief. We look at if a child has oral sensory difficulties, muscle weakness, feeding difficulties, or motor planning difficulties. In brief, this is what we look at to kind of figure out, does the child need oral placement therapy? If these are not there, we don't have to put it in place. Traditional speech therapy works. And that's what we look for. Now, how is it all connected? Like I said, sensory system. If you feel, okay, I'll give you a grosser example. If your legs are numb, when you sit in the wrong way for too long and your legs get numb, if your legs get numb, will you be able to walk? Very difficult to walk because your legs are numb and I'm not getting sensory feedback. That sensory feedback is important. So what do? Automatically, you're going to shake your legs out or massage your legs to get some feeling back in, right? Then you get pins and needles. Will you still walk? Now again, you won't walk. Why? Because I'm not liking the sensation that's coming back up. It's painful, it's uncomfortable. Even then, I won't create a movement to walk. So if I feel too much or if I feel too little, I can't create the motor skills that I need to do what I need to do. So your sensory is the same thing in the mouth. For example, if any of you have gone for tooth extractions, you have an injection that's put in to numb the area. And what happens? Do you feel that you can talk clearly after that? You feel like you're slurring your speech. You're not really able to talk properly. You feel like you're drooling. Why? Because you're not getting the sensory feedback because that whole area has been numbed. So now speech gets affected because the clarity gets affected because you're not getting sensory feedback. So sensory system is very closely connected to the motor system. Only if you feel can you move, right? And only if you move can you create the patterns that you need for something like feeding. Because that's the first patterns, those are the first patterns that come in. Children don't are not born learning how to talk or knowing how to talk, right? They don't have sounds initially, they have just the cries. It's the feeding that first comes in, and this feeding is what builds a baseline, the movements, the prerequisites for speech to come in. As the feeding patterns come in, as those movements come in, it creates a foundation for speech. And again, speech, if there are oral skills that are affected, speech clarity also gets affected. Again, if sensory system is affected, guess what? The feeding will get affected. If I'm hypersensitive to certain input, I don't want this food in my mouth. It feels very uncomfortable. So I'm not going to eat. So now you have feeding issues that crop up. The same way, if I'm not feeling enough, like I said, you have an injection in your mouth, your speech clarity is affected. So you see, everything is connected. These are the 4 areas we look at. And this is what a holistic program should look at. Whether you call it oral placement therapy, oromotor therapy, whatever therapy you want to call it. And if you're working in the mouth, you got to make sure these 4 components are connected. You cannot work on just the speech. You cannot work on just massages and say speech is going to develop. You can't just work on just exercises and say speech is going to develop and feeding is going to get better. It has to be combined. It has to be put together. That's when you will see results. And I've seen a lot of times when it's just exercises done or just massages done. And then therapists and parents say, but there's nothing happening now. We've been doing this for so long. This doesn't work. Well, it does work, but you've just got to combine the components the right way. That's the idea, right? Now, sensory processing, like I said, is one of the big ones. Now, you could have a child, like I just mentioned, hypersensitive, meaning really finding it difficult to take in the sensory information. So really up high here. Hyposensitive, meaning that I'm not feeling enough in my mouth. And so what do these children do? They go and seek things. These are the children who will be mouthing things all the time, biting their t-shirts or wanting food constantly to chew on. These are the children who are constantly seeking because they do not have enough input coming in the natural way. But you could also have sensitivities where it's fluctuating, where in the morning I could be fine and by afternoon I'm seeking a lot. And you could have a fluctuating system too, an example. Or you could have a mixed sensory system in terms of maybe one side of my mouth I'm very comfortable and it's normal sensory input, but the other side is hypersensitive. Do not touch that left side or do not touch that right side. So I could have a mixed sensitivity. Or outside I could be very comfortable, inside do not touch me, inside do not put anything in my mouth. These are the children where you'll see brushing is extremely difficult, right? The outside, if you touch them, they're like fine. Inside, you put a brush, no, I want to run away. I hate this process, and then the fight starts, right? So that's where you could have maybe a mixed sensitivity, or maybe it's overall hypersensitivity. Those are things that we have to check for and kind of figure out. You could also have the other extreme of tactile defensiveness, where everything is do not even touch me, do not come near me. I do not like this input that's coming to me. And a lot of times that comes there is something underlying this one compared to the others. This one is where your defense reflexes are very active. That's when the tactile defensiveness comes in to a large extent, where my defense reflexes, your primitive reflexes, are very active. And if those fear reflexes are very active, everything is no, please stay away. And that makes it very difficult for us. So you can't just bulldoze and say, no, let's do these exercises. I'm going to stick this into your mouth and you just cry through it. And that's not a problem for me as long as we get somewhere. No, absolutely not. We cannot work with a child when a child is crying through the process. OPT is never done that way. If any of you have seen OPT done that way or any kind of oromotor work done that way, please know that is not the way that OPT should be done or any kind of oromotor work should be done. A child should not be crying through this process. If the child is crying, it's information for you as a parent or a professional that, okay, they are sensitive, they are uncomfortable, something's up here, and we have to build it up, build their trust, play with them, let them know that it's safe. And only then can we move forward. Right? So there is these things that we also have to keep in mind when we look at the sensory system. And it's not just the oral sensory system that's most times affected. We always have to take a bigger picture, the body. What's happening with the body? Because if you see it in the mouth, there are 90% chance that there is something happening in the body too. And everything starts gross to fine. Mouth movements, very fine motor movements, body, gross movements. If you don't settle the grosser movements, the grosser sensory processing, it is difficult to work on the finer sensory processing. Right? It can happen parallelly. I'm not saying you have to fix one thing and then get to the other. No, but you have to understand, you have to look at the body all the time. It has to be body to mouth. It cannot be, oh, we just work on the mouth alone. I did that. And hence I'm saying it from my experience that it doesn't work, because I did that for the longest time because, hey, I'm a speech therapist. I should be doing that, right? But I learned the hard way that no, I shouldn't be doing that. I should look at the body. I should look at the whole child and then look at, okay, what can I do in the mouth? And that's when things work. If you have challenges to the tactile system, these are some of the things that you would see. If there's hypersensitivity, you would have the child avoiding teeth brushing, hair washing, washing their face, feeding problems, extreme sensitivities to food textures or temperatures, poor use of their lips and tongue, on alert all the time, hyper vigilant all the time. If they're hyposensitive to touch, you would see them mouthing a lot, overstuffing their mouth with food. Like before that first ball of food has finished, that second ball of food has already gone in. They could be messy eaters. They're not aware of saliva building in their mouth, and that could cause drooling. Again, poor use of lips and tongue. Now, if you see whether it's hypersensitivity or hyposensitivity, both times it has affected the motor function of the lips and the tongue. Right? So any kind of sensory processing difficulties in the mouth do cause those motor dysfunctions. Right? So simply put, sensory difficulties very closely connected to motor difficulties and vice versa. It is you cannot separate sensory and motor. You cannot just do one and hope the other one comes up either. You have to work on both parallelly, and you have to understand that they're very closely connected. Okay. And then if you see muscle strength issues, which is common in children with cerebral palsy, Down syndrome, and other GDD, you do see, even in children with autism, at times we do see muscle strength issues. It's not that it's they're excluded from muscle weakness. We do see it, but that's the thing. Every child is different. We've got to assess all of these. We have to check the sensory processing. We have to check the strength of the muscles. Are they able to use it the right way? Do they have enough strength to support speech and feeding? It's not that I want you to hold 100-kilo weight. I want to know, do you have enough strength to support speech and feeding? Because those are the two functions that we have. So this is a question for all the parents or whoever's here. What do you think is the most important articulator between the jaw, lips, tongue, cheeks? What do you think is the most important? Do you think you could put it in the chat or unmute and say? It would be really interesting if you could participate, because I'd like to know your thought process. Would you be able to tell me?
The lips and tongue and jaw.
Okay, that's all three. Which is the most important?
I think tongue.
Tongue. Okay. All right. So I have a few answers coming in the chat. Please do continue. I think some of you have heard me talk before. Also, I see some names here. Okay, so some of you say jaw, some of you say tongue, some of you say upper palate, tongue again, tongue movement. Any more? I know there are a lot of you here today. Don't be shy. Please do answer. Okay, jaw. Anybody else? Okay, so we have we have some tongue, we have some jaw. I'm not understanding what this is. Did you say saliva? Saliva? It's written in Hindi. I'm trying to figure out if that's what it means. Mamta?
Yeah, looks like saliva. Yeah.
Saliva? Okay, all right. Not an organ, not an articulator. So it's not one of them. Okay, so we have between jaw, lips, and tongue, different answers. Okay, so let's look at slightly differently now. What I would like to show you is this representation, and let's see if it makes sense. So imagine that you have the best acrobat in the entire world with amazing flexibility and movement up here. Okay, this yellow circle is that acrobat, best one. Awesome, right? And of course, to be on the top here, he or she has to be supported by the green circles and the blue circles. Now, what happens if that day that they're doing something and they're practicing or they're putting up a show, the blue circles are sick or they've got some sudden pain or they just can't do it. They don't have the strength. What's going to happen to that best acrobat? No matter what, if they fall, you are not going to get the support, and that's it. You might be the best acrobat, you might be the best organ muscle that you need, but if you do not have the foundation or the people to support you, you are going to fall. Now, what is that support? So for those of you who answered, pat yourself on the back. For those of you who gave me this answer, the jaw is the base. It is the jaw that supports the movement of the lips and the tongue. If the jaw does not have good foundation or does not have enough strength, does not have enough control, it will not support the movements that the lip and tongue are supposed to develop. So this is how it is. This is our pyramid for the oromotor functions. It has to start with the jaw, then the lips, then the tongue. And that's how natural development happens for everybody. Okay, we need to get that stability to get that fine motor skill of the lips and the tongue. So your tongue is, yes, the finest motor muscle which needs a lot of control, a lot of speed, a lot of rhythm, a lot of coordination. Yes, absolutely, it's needed. But without the jaw support, it's not going to be able to do what it needs to do. And a lot of our sounds are tongue sounds. There are lip sounds, there are tongue sounds. So for that to come in, we need to work on the jaw. Okay, I hope that was honest. So what happens if the jaw is unstable? These are some of the things you'll see. Something we call a jaw slide. A slide is when the jaw is moving to either side. And this will affect clarity of speech. You see how I'm talking? When I slide my jaw, and this you see very commonly with children who have weakness, they kind of slide their jaw to one side. This is called a jaw slide. It can happen towards one side or the other. Another thing that we could see if there's weakness or it's not stable is a jaw jut. That means the jaw is pushed forward like this. It's pushed forward. If you can see from the side, pushed forward. That's a jaw jut. Right? Again, that is not where our mouth is aligned. And if it's out of alignment, we don't create the clarity that we need or the fine motor movement that we need. And this is, again, we commonly see where there's weakness with children with cerebral palsy. We see it with children with Down syndrome. And these are kind of things that immediately tell us, okay, there is some weakness here. We need to sort this out before we actually go into speech and feeding properly. You can also have the child having a lack of dissociation, meaning they move their whole head towards the spoon or the tool that you're using. If you're using, say, example, a chewy tube, they'll move their head towards that chewy tube. They're not able to understand this head stays steady and I only need to use my jaw, or I only need to use my lips, or whatever it might be. It's all moving as a unit rather than separated. You could also see a high jaw fixed posture, meaning the jaw is like this. I've fixed it in this position. And if I fix in this position, again, listen to my speech. It's not very clear. Right? The clarity gets affected. And this time again, we see that with children who do not have a lot of control, they kind of fix it. You also see this very commonly. I had a little boy where I saw this. He was so sensitive to things in his mouth that he'd just be like this all the time. He'll keep his lips tightly closed and his mouth tightly closed, doesn't want to open it for food, doesn't want to open it for speech, nothing, because we're so sensitive. So that's a high jaw fixed posture, which will affect, again, functional use of the mouth. Or you could have open mouth or low jaw fixed posture where the mouth is always open. Now, you could have it in different ways. I see this also across the board of neurological conditions where the child's mouth is sometimes just open. And if the child's mouth is always open, they will start being mouth breathers rather than nasal breathers, and that will affect their sleep, that will affect their speech, that will affect their posture. It'll affect a lot of things if they are mouth breathers. So these are some of the things that we also look at. Now, how does any of these things, any of this instability as such affect speech and feeding? You'd have what we call poor grading, meaning poor controlled movement, poor lip closure, poor dissociation of the jaw, the lip, and the tongue, knowing that these can be separated, and hence poor speech clarity. So here again, the jaw is affected, we get into poor speech clarity. Same way, if any of these things are seen, you see drooling, water spillage, messy eating, poor chewing, manipulation of food, poor manipulation of food, preferring soft food, inability to eat from a spoon, and hence poor nutrition. So again, the two functional aspects of the mouth, speech and feeding, have been affected if the jaw is not strong enough to support these movements. Right? I'd like to just give you an example before I go into this. And I'd like all of you to just try it out. It's an interesting activity because to understand why the jaw is more important. If you can lock your jaw in an open position, okay, and then just count 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. First one. So let's try this out. I'm hoping all of you try it out with me because then it's more fun and more interactive. Lock your jaw. You can move your lips, you can move your tongue, but you cannot move your jaw. It's in open position, okay? Okay, that's how I could say it. All right. Now let's try it a different way. Lock your tongue behind your teeth. Okay, just lock it there. And now say 1 to 10. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Which one was clearer? Was it where the jaw was locked or the tongue was locked? Nobody? Tongue? When the tongue was locked, you got more clarity?
Yeah.
Yeah. So that should tell you if the jaw is not moving enough and doesn't have enough support, see what happens to the clarity automatically. Even if you locked your tongue, there's still clarity of speech coming through. So it's not the tongue. I hope this made it a little bit more clear about why I say the jaw is the support. Yeah? Okay. Let's go into the next one. Another aspect that we look at. Where's my share? Okay. Another aspect that we look at is feeding, which is a big concern, right? Why do we look at feeding at all? Because children need to thrive, right? Children need to eat. They need to get adequate nutrition because if you do not get, you can cause weight loss, it could cause obesity, it could cause constipation, dry skin, trouble paying attention, tooth decay, depression, high blood pressure, heart disease, you can name it, pretty much everything will come on there if nutrition is affected. So why do we include feeding as part of this program? Because the movements that we require in feeding are like the prerequisites you require for speech. Those movements, I'll give you an example. By 6 months of age, most of the babies are moved into solid food, from breast milk to solid food. That's generally when it starts. right? And so what do? We give like poshtik ragi, I don't know, whatever we give with the spoon. Right? So what is the baby learning when they have to eat from a spoon? They learn that the tongue has to go in. Otherwise, they don't and push all the food out, which is the first thing you will see, because that's the movement you get when you're suckling from the breast, the tongue going in and out and in and out. So when you introduce the spoon, they'll also do that and push all the food out. But slowly they learn, oh, all the food's going out. That's not the way to do it. So they start pulling their tongue in and they start closing their lips around the spoon. Now, the closing of the lips around the spoon, how does it connect to speech? What kind of sounds do we make with our lips closing? We can do we can do p, we can do b. Correct? So the movements that you're creating through the feeding patterns in that first year are what is helping the speech develop. They're like the prerequisites. Right? And that helps to normalize all the skills that are needed both for feeding and speech. So that's where we include feeding. Because again, if a child is hypersensitive to textures, temperatures, or taste, I'm not going to make movement. And if I'm not going to make movement, I'm not going to have the freedom to create the movements I need for speech too. I'm not saying it happens all the time. There are times where only feeding has been affected and speech is fine. But when we dig a little deeper, because I've had children with only feeding issues, speech is not an issue. But when we look at it a little bit more, we'll see that some of the clarity of some of the words are not in place because they have not had the freedom to move them out as much as they needed to. So there is an impact that it has. So that's why we include feeding, right? And some of the difficulties that you could see, as we mentioned, drooling or overstuffing, poor chewing, refusal of food, spontaneously eliminating previously eaten foods. Like I had it today, but tomorrow I don't want it. Or I had it for a month now, the child is not eating. And it's extremely difficult for parents at that time. It's like, they're eating only dosa now, they're not eating dosa now. What do I give them? These are the kind of difficulties we could see. And then they're trying to give this food and that food and having 3-4 meals happening at one time just to see if the child will eat something, because the child needs to thrive. You could see poor use of the lips and tongue because of feeding difficulties. You could see inability to eat from a spoon or drink from a cup properly or suck from a straw, refusing to touch certain types of food or the utensils. And hence, what happens? Nutritional deficiencies, inadequate hydration, limited types of food, which will affect your physical health. Right? Poor weight gain could come in. They might have difficulty sitting for family meals. And that's important to build the bond, to be able to sit together, because I have some children who cannot even see the sight of somebody else eating. They'll gag or they'll run away. And it can get to that extent. You could have stress and anxiety always around meal times. What happens if you're constantly under stress? You won't be able to function well. Your brain is always under that, then the defense mode. This will cause a lot of psychological and physical discomfort, not just for the child finally, but psychological stress for the whole family. Right? So that these are the reasons that we have to look at feeding too, and where we use oral placement therapy for the same. But we also need to distinguish, is it a medical issue? Is it a sensory processing difficulty? Is it anxiety? Or is it behavioral? Right? We got to distinguish between these three too. Because if it's medical, oral placement therapy is not going to help. Because we have to look at the medical background. What's happening? Are there gut issues? And we have to look at working with a functional medicine doctor or somebody to help with the gut issues. If there's reflux, there might be medical intervention that's needed from the doctors. If there's constipation or allergies or any of these, we have to look at it from a different angle there. We can't just say, hey, I'm going to do exercises for you and that's going to sort it out. No, it won't, because the core issue has not been looked at. Right? If there's a sensory processing difficulty, okay, they're not able to take certain types of textures, some taste. Okay, we have to slowly introduce that in a friendly way. Okay, that's something that we have to deal with. If it's anxiety, there is a condition called ARFID, that is avoidant restrictive food intake disorder. That is a DSM-5 classification. There is a condition called ARFID where the children are not able to eat because of severe anxiety around food. If that's the case, then we have to deal with it differently. And we can use OPT, but the approach will be very different. If it's behavioral, again, the approach will be different. So that's where we have to kind of figure out what is it that's actually happening, right? And we have to put all of that information together. The last one we look at is speech, because again, that's the functional aspect of it. But why isn't speech developing? Is it because of weakness? Or is it because of motor planning issues? Right? And that's what praxis is. Praxis is a process where we have an idea. Oh, I have to pick up that glass. How do I pick up that glass? So I need to first say I have to pick up the glass. That's the first idea. Okay, I'm thirsty, so I have to pick up the glass. Idea has come. Now I have an overall plan that comes in saying, okay, to pick up the glass, I have to extend my hand. Okay, I have to reach my fingers around the glass. I have to hold it, pick it up, bring it to my lips. That's an overall plan. Now I have to program it saying, okay, how much pressure do I put? How much arm, I'm like, how much of my arm do I have to extend for it? The finer details have to come in when you program. And then finally, you're able to execute it. And then you get feedback. Oh, wait, did I just pull it so hard that the water spilled? Oh, maybe I put too much pressure, right? I didn't move it enough. I get feedback. Oh, next time I have to be a little softer with my approach to picking up that glass. And that's the same thing that happens with speech. You get an idea, I have to say, mama. Okay, I know I have to call her. I get it. So I get a plan. Okay, how to say mama? Where's I have to do I have to do I have to do ah. Okay, now we program to be specific. How much of my lips do I close? How much of my mouth do I open? Where do I bring vocalization out? Where do I use my nose? How do I coordinate between the two? The finer details have to come in, and then I execute it. Right? And then I get a feedback. Did I say mama, mama? Did I say mama? Or did I say mama? And if I said it wrong, we get feedback and we correct it. That's the whole process of praxis. And all of this has to be done with control, coordination, and of correct sequencing. If it's not done, you will have, again, the clarity of speech getting affected. So that's what we call apraxia or dyspraxia. Praxis is the execution of a voluntary movement, right? Apraxia is a total loss of that. Dyspraxia is a partial loss of that. Okay, it's just technical terms. You don't have to worry too much. Just to give you, I'm sure pretty most of you already know these things, so I'm just going to move forward. Now, childhood apraxia of speech, the core impairment is not the execution. The core impairment is in the planning and programming process. How much do I move? What timing do I move it? What pressure do I put? These finer details are lost. So the child gets the idea, but he doesn't get the signal from the brain of what I'm supposed to do about it. And so I'm not able to execute it. So the rest of the process goes off because in between there has been an issue. So that's the core impairment, childhood apraxia of speech. This is what we look at. It's not an execution problem. It is a programming planning problem that hence affects execution and feedback. Okay, and these are some very discriminative characteristics, meaning only in childhood apraxia of speech that you see. So if you see this with your children, right, these are the things that give you information. It's traditional speech therapy will not work because they are not able to take that visual auditory information and take it forward. That's why traditional speech therapy won't work at this time. So if you see this in your children, please understand the way, what's happening and why they're having these difficulties. So you could have difficulty initiating a movement, maintaining the movement, or stopping the movement. Like if you tell a child, let's say ball, you could have ball, or then they might have that, but no sound coming out. Initiating it. Sometimes the sounds are so they can't maintain the sound and it becomes like very short bursts. And that affects your clarity. If I'm going, I've got each sound, but I'm not able to maintain that vocalization to actually make it sound like a word. Right? The biggest ones are the difficulty moving from one position to the other. So if I have to say mama, to go ma, to move from M to A to M to A, right? We see a struggle. So they might just go ma and stop because they don't know how to go to that next part. And that's the one that stands out a lot. You could see that they're groping, like they're trying to figure out what is it I'm supposed to say, and you see a trial and error behavior in their mouth, right? And this generally you see when it's elicited, like, can you say mama? When you're asking them to say it, this is when it's more obvious. Spontaneously they might say it when they're desperate to say it, or desperate to call you, or they're having fun and they say it on their own. You might not see that issue, but when you ask them to say it, when it's elicited, that's when you see these difficulties crop up. When you try to increase, now for children who are speaking also, but when you try to increase the number of syllables in the word, you make the word more complex, you'll see that they have increased difficulty articulating it. You will see vowel distortions, not substitution. You're not saying R for O and things of the sort, but the R itself sounds very different. Like it's not an R. Right? You will also see one of the big ones is prosody. Prosody is your intonation, the tune that you use when you talk. You have a rising pattern, you have a lowering pattern. You have different patterns when you speak. If I speak like this to all of you, you would all go to sleep. Because that's not how we talk. We have a tune, an intonation pattern when we talk, but our children with CAS find it very difficult, and they put equal stress, so they sound monotonous when they speak. Right? That is also a difficulty that they face. You could also see where inconsistency in the voicing, that I'm saying, for example, and I'm just, no voice is coming up. So I don't know when to put in that voice, when not to put in that voice, when it's just a soft one versus when it is papa, I have to bring. So it might also, these are things that we see, or when to use the nasal sounds ma, na, and you might not use it the right way. So there's an inconsistency there and timing errors that come in. These are things. Intrusive schwa is just like a sound that comes in. So if, for example, ball, or if you ask the child to say ba, abba, there's an that comes in either in the beginning, or it could be baseball, put an in the middle, or it could be an in the end. That's the schwa. That is again, because this also happens as a learned behavior, because a lot of times we are teaching our children, say for example, ball, okay, ball, now if you're teaching them, they're going to put ball, and that's going to become ball, because you're stressing on trying to get that last sound that you put an there. They will learn the and breaking that pattern is the most difficult thing. So if any of you are teaching your children words, please be extremely careful about teaching that last final sound. Do not add anything extra. You want to stress on it going, let's stop. Don't go into ball, because that will create a whole different pattern for them. Then you can't blame them that their clarity is wrong. Right? It's probably because as professionals and parents, we might have put that across when we are stressing, and it's a natural process. So if you're aware of it, at least you don't have to put it in. Yeah. Another thing that we see is a very soft voice from our children with CAS. Their voice is not very loud, and this is one of the common things that I see a lot of parents telling me. They're trying to talk, but their voice is so soft, and I can't hear them, and nobody else can understand them because of that. Another big one is history of pop-out words, meaning I have parents who tell me, he was saying this word for 2 months and then it disappeared. Or I heard him say it out of the blue and then he can't do it again. That's another big sign of CAS, or childhood apraxia of speech. Okay, so again, if it makes sense to all of you, this is how we kind of look at putting it all together. So who will benefit? Children with feeding issues, adults, the age doesn't matter. Individuals with feeding issues, the ones that we talked about, or speech difficulties. That's when we use oral placement therapy or any kind of oromotor therapy that is targeting to these two areas. Okay, so what are our goals? Our goals are to create awareness, because like I said, sensory system. So create awareness. You have a tongue, you have lips, you have cheeks, you have a jaw. Did you know that? Because if I don't have awareness and I have hypersensitivity, how will I move it? So we create awareness. We create normalization in the tactile sensitivity. Remember, if it's hypersensitive, how will I move? Okay, you've got to bring it down. Normalize it. If it's hypo and you're not feeling enough, okay, we've got to bring it up. Right? So whatever it might be, we've got to balance that out and normalize it. Then we look at teaching normal movement patterns, the right movement patterns for speech and feeding. So, for example, when you teach, I'm just going to take this out so you can all see me when I do this. For example, when, wait, can I just spotlight myself? Yeah. For example, when we have speech therapy activities or home activities where we're saying, okay, I'm going to put honey here, lick the honey. Okay, I'm going to put honey here, lick the honey. Now, tell me which speech sound requires your tongue to come out of your mouth? Any speech sound that requires your tongue to come out of your mouth? There is one. Actually, there are two. But the kind of movement it needs is very different. Do you know which sound requires your tongue to come out of your mouth? Any ideas? You can put it down in the chat if you want. Ah? Well, ah doesn't require you to put your tongue out of your mouth. Ah, we don't do ah. We're not doing ah, we're doing ah. Tongue is inside. L? Do we go L? Ball? Lollipop? Or do we go lollipop? Where's the tongue? Still inside the mouth. Yes. Th. TH. Your th, your the. Those are the only ones that require your tongue to come out for speech. The, and see how much requirement is there. Th, the. It's a very small movement. So when you're teaching the child tongue wagging and doing this, it's not helping for a functional purpose. Because what is the functional purpose we have? Feeding and speech. Now for feeding, yes, if you want to lick the corners of your lips, we do that. If there's something on our mouth, yes, it's a functional thing. So you have to know, what are you working for? I don't need my tongue to touch my nose. If it's a fun thing, yes, but for a functional purpose, no, I don't need it to. So if you put honey here, it doesn't help because the movement is needed inside the mouth for a l or a t or a d or a n. It's behind your teeth. It's not outside. So please don't teach your children l. Because l is not how we produce l. It's behind your teeth. That's the position. So that's why some of these motor activities will not work, and they teach the child exaggerated movement. Now I'll have to talk and I'll say lamb. It will sound odd when you're starting to put that into words and sentences, because the speech sounds have very specific positions. I'll give an example. And again, like in Malayalam, we have very rich with lots of sounds that we have. All right. I'm just going to give you an example. If you take, and I'd like all of you to try this again, take your tongue tip to just behind your teeth to say l. Now start taking it backward all the way and see what happens to that l. A slight change in position has changed the quality of the sound. And that's why it's important to know, where does that tongue tip go? Where does the lip go to create the right sound? Otherwise, it becomes a vague sound. Now, if it becomes a vague sound, okay, you've got a vague sound. Now, just imagine when it's put in speech. Then you'll say clarity is gone off, because that quality has gone off. So that's how specific, that's how fine motor controlled movement speech is. So when we just say, why my child is not talking like that, he has to talk, there's a whole lot of factors there that have to come into place. And if they don't have all of this in place, it's extremely difficult for the children. It's not that they don't want to. Please understand, it's not because they don't want to. It's because either they're not getting the signals on how to, or they don't have the strength for it. So we got to look into both these factors. I'm hoping this makes sense. Let me just go back quickly. We have, okay, I think I'm overshooting the time a little bit. Okay, so let me just, so these are the goals that we're looking at creating normal movement patterns, good control in the movements that will support feeding and that will support speech. And this, just to quickly, like I said, I wanted to just quickly help you understand, see where oromotor development is, and look at all the things that I needed behind that. So if you are looking at speech, hey, even I'm looking at it. I'm a speech therapist. I also want it, right? But if I don't have a lot of these systems in place, a lot of this processing in place, getting to speech becomes 10 times harder for the children. And will an individual want to work 10 times harder? Or will they just say, I'm done. I don't want to do this so much. And hence, children start hating speech. And they start hating speech therapists because we are here to say, can you say this? Can you do that? I'm like, oh, I cannot do this. This is difficult for me. I'm going to run in the opposite direction. So we have to look at the rest of it. And this is this is the pyramid of, sorry, a little fast, pyramid of learning that I'd like you all to be aware of. Now, for 20 years, I worked on the top layers. Okay, that's my profession. I worked on the top layers. It is in the past few years that I have realized that if I work from the bottom up, I get access to speech, language, and communication much faster. So the children are more comfortable and the parents are more comfortable. I'm not saying we don't give support at the speech level that everything magically comes in. No, that's not what I'm saying. But I'm saying it makes the learning process 10 times easier if we work from the bottom up. And that's what I have seen personally and professionally, where if I'm working from the bottom up, from the reflex level, and I'm integrating those reflexes, and the parents are doing that work at home, then I see better sensory processing. When I see better sensory processing, I see better movement patterns. When I see better movement patterns, then I can support speech to get to communication, attention, academics, executive function, and all of that. Those are the higher levels. But a lot of times we start there. We say speech is a problem, we start with speech. We say communication is a problem, we go straight there. We say counting is a problem, we go there. Children will learn. It's not that children don't learn. And I'm always amazed by the children who still pick up, even though they're working 10 times harder than all of us, they're still learning. And I have to hand it to them the way that they continue to learn and sometimes do it for the parents, for the therapist. Okay, let me do it to make you happy at times. And I'm amazed by them. But if we can make the process easier by working our way up, you will see that the children get towards that speech, language, and communication faster. I had a little boy who's 10 who has severe dyspraxia. The childhood apraxia of speech is quite severe for him. He has no sounds. He tries, he attempts, but he can't get through. Very intelligent child. And when we started reflex integration, the mom started saying within the second month that, hey, he's doing movements that I've never seen him doing. He's starting to get more strength in his body. He's doing better in OT. Like the OT is also surprised that suddenly he's picking up on movements. Okay, great. By the third month, we saw, hey, he's getting buttoning. He could never button. 10 years, he's never buttoned. Suddenly he's buttoning his shirts. He's getting fine motor skills. They were not taught to him. But also at the same time, the mom started saying, he's approximating speech. He's starting to bring out sounds. He's trying to attempt words. Hey, no speech therapy was done then. And that for me was magical. Without speech therapy, and you started working from the bottom up, look at the connections that started getting created on the top. So it's a sincere request to all parents, when you're working with your children, please work from the bottom up. Really look at professionals who can help you there, because that is what is going to make it easier for them. All right. And moving on from there, I just needed to put that in because it is a passion of mine to put that across, because I am seeing those changes every day. And so I wanted to put that across. Okay, so when we do oromotor work, we look at posture because it's extremely important. The more stability we have in our body, the gross body, the more mobility we have in the fine motor skills. Right? And it's the same for writing. If you don't have good posture, your writing is going to get affected. And that's why OTs will always talk about the postures, like, okay, they need to be able to sit up more straight, not curved. It's the same for speech, which is a fine motor skill. Right? When we do sensory work, we use a variety of things, and you can use everyday things at home. Right? You don't have to get everything specialized and buy a lot of tools. You can have just one or two tools that you could use initially. These are some of the things just to bring your attention to it. There are different ones. These are like just 199 rupees and things of the sort. If the child is not biting too hard or chewing on things too hard, I might use some of these softer ones. Right? But you do have sensory tools that you could There are a little bit more expensive. These are not all of them. There are more now coming into the market that you could use. But if you're looking at sensory work, you got to look at the purpose of the sensory work. You have to have a goal when you do sensory work. Not like I just do massage, 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 massage. I'll do here, I'll do here, I'll do here, I'll do. That doesn't work, right? It has to be for a purpose. Say, for example, if you're doing this massage, now what is the purpose of this? It is to lengthen the cheek muscles, bring more awareness to the cheek muscles so that it can move into a position like this. And what is this position for? For speech, I can go for a oo, o, w, and any combination of these. For feeding, I need to bring my lips forward to be able to clear a spoon. Now, this is a functional movement that we want, and that's why we do that certain massage. So if, for example, I'm going this way, I would do it to encourage swallowing. If the child is drooling, I would take it the other way to just encourage that swallow reflex, like, oh, okay, the indication that I have to swallow, right? So the movement you create, with the massages should be functional, should be for a purpose. And it should not be random, whether you go outside or whether you go inside the mouth too. We can do on the cheeks, you can do under the lips, you can do on the sides of the tongue. Please don't push the tongue from the front, because the more it's a muscle that's held by one, you see that string at the bottom. So if you push it, it comes back out. That's an opposite and equal reaction. So for children who have a lot of where the tongue is out a lot, if you keep pushing the tongue and saying put it in, it's going to come out more, because that's the stimulation you're giving. So instead, what we encourage the parents or the student to do is, let's move the tongue to the side. Can we move it to the side more? Okay, can we now pull our tongue in and move it to the side? Because you need lateral movement or sideways movement of the tongue, say, to push food to the molars. When food comes in, what do? We take it to the side and we chew there. So it is a functional movement. It is also a prerequisite for speech, to have sideways movement for that up and down movement to come. And why do we need up and down movement? Ta, da, na, la, ka, ga, sa, sha, cha, ja. You have all your sounds coming in there with that up and down movement of the tongue. So this is how we kind of put it, slowly working on the sensory work has to connect with the motor work. It's not massages and I'm done. It's not massages for 1 hour and I'm done, because you'll overstimulate the child. It's massages that are done for a few seconds just to wake the muscles up, and then it's combined with motor activities. Motor activities, like you see on the screen here, different kinds of motor activities, again for a purpose, not randomly done. If it's done randomly, you don't know what your goal is. And if you don't know what your goal is, how do you translate that to a speech movement? Just because I'm chewing on a chewy tube 20 times, 30 times, 40 times doesn't mean anything. It just means I'm chewing on it. Right? Sometimes you get better chewing skills, awesome with food, but doesn't automatically translate to speech all the time. Right? Blowing is not done for the sake of blowing. That is the first whistle. We'll say, can you get the skill of blowing if a child doesn't know how to blow? Yes, we might start with that. But after that, that's not the goal anymore. The goal is to get more control over your lips. The goal is to pull your tongue in more. The goal is to get more jaw stability. The goal is to get more abdominal grading, meaning learning how to release that air slowly and not do. Because if you do that and you learn only how to release with that power and release it fast, you don't have air for speech. We talk like this. Then when we talk so much in one breath, that means we're releasing the air very slowly. The diaphragm is doing that work. And that's why we look at blowing going into different goals, from learning the skill of blowing so that you know volitionally that I can bring air out, because only then speech can be produced, right? To learning how to control your lips so that we can get oo and p and b and w and a lot of other sounds. Knowing how to take your tongue in so that it can move more inside the mouth, which is where all the sounds are produced, right? To knowing you have to release that air slowly so that I can talk so much in one breath before I take the next breath. And a lot of times when our children do not have good breath control, they will speak fewer words. because they don't know how to use their breath properly. So breath support is extremely important. That is why we do some of these activities. I'd like you to understand the rationale behind it. So it is not run randomly. Whether you're using the bite blocks, it's to build strength at the jaw level, to let them understand that, oh, I can hold the jaw in this position, I can hold the jaw in this position, I can hold the jaw in this position, because these are your different vowels. E, A, U, O. You move the jaw very slightly to be able to get these different vowels. And that's why we use those bite blocks. Right? So tools need to be used for a particular process. And if it's feeding, we make food a friend. That's how we start. We help them wash. Can you help me wash the vegetables or fruits? Or let's play with the food. We can mash some potatoes and let's make like Play-Doh. Let's make some shapes out of it. If the child has difficulty looking at it, smelling it, listening to it, touching it, it's not going in the mouth. So that's where we try to make food a friend through different play-based activities. Sensory play is extremely important to calm the system and integrate the sensory processing. Right? And then we look at more specific functions in terms of, can you drink from a cup properly, or is it like a bird feeding? I just open my mouth and it's just poured in. Can you close your lips around the spoon properly? Can you suck from a straw? These are functional feeding activities that we look at. And then finally, we get into the speech work. It's not done after 1 year. Speech work is done as soon as the movements are starting to come in place. And if you see, I see like, oh, lip closure is easy for this child. All right, let's move on. Let's get into purr. Let's get into let's get into purr. Right? Oh, they're able to open their jaw with some control. All right, let's get into some vowels. And then we start creating at the sound level. Then we put into combinations. Because if a child has apraxia of speech, for example, they have to learn how to combine, because that's one of the biggest difficulties they have. So how do we combine? For those who don't have CAS and who had weakness, so if you have strengthened the muscles and they're able to produce the sounds, they automatically start going faster into these combinations. And what kind of words do we use? Not the flashcards. You want to use words that are meaningful to the child, that are part of their play routines. You want to keep the intrinsic motivation very high. You want to use words that are not just, hey, you say this, okay, you say that. For them, it's like, why? Why should I say these words? What difference does it make to me? So you've got the words that you choose should be functional, should be relevant to them. That's when they have a motivation to say it. Okay. So in summary, OPT is one component. It's not the end all. It's one component of a holistic program. It cannot be done in isolation. All right. It's not meant to work on non-speech oromotor movements. Just do the chewy tube, just do the chewy tube, just do blowing. This is non-speech oromotor movements. It's not meant for that. It is meant to take those movements and translate it into feeding and speech movements. Okay, that's what the idea is. Now, this is again my building blocks just to help you understand this is what has helped me. So I just thought I'll show this to you. If we are trying to get to speech, these are my building blocks that I use, which has helped me go towards speech. So I'm just going to give it a pause in between so that you can take a look at it. I'm hoping it stops there. Yeah. So if a child is not regulated and is very anxious, you are not going to be able to connect with them because they cannot connect when they're in that anxious stage. And I'm sure as parents, you've realized that. Right? You can't do work with them when they're in an anxious state. So you're first looking for regulation to help connection come in. If you have connection, then you can get interaction. If you can get back and forth, then you can build communication. If you can get communication, words are a byproduct of it. Speech is a byproduct of it. If they need motor support, yes, we can give them motor support through tactile cueing, tool cueing, any kind of cueing to help them get to that speech, because now that speech is meaningful to me. It makes sense to me. I want to use it. Not because I have to name 10 flashcards, but because this is fun and it's play and I love being with mama and papa or the therapist. There is a meaning behind it. Then the speech becomes meaningful and interactive. Otherwise, the speech becomes robotic, monotonous, irrelevant to them, and you don't see them using it a lot. Only when you say, can you say this or say this, then I'll give it to you, then they might will try to say it for you. But will they generalize it? Not always. So these are the kind of things that have helped me. So just giving you a visual in case this is something that will help all of you to know, where do I need to start? And this is something I tell professionals also. Where is the child? Okay, you've got regulation, you've got connection, you've got interaction. Brilliant. Let's go beyond. Okay, you don't have regulation today? No, no, let's not go to speech. Let's start here. But sometimes you could go quickly up also if you help them regulate and they're in a good space. You could go up the ladder again faster. It's not that that day, okay, we can't do anything. It's about how can you help them regulate to go up that ladder again. And there are the days that they might not be able to do that. Change the activity immediately. Don't get them into that, continue in that dysregulated state. It's a lot of stress for them. Okay, and that's it. I think that was it. Yes, that was it. Thank you so much. I'm sorry if I took a little bit more time.
Thank you so much, ma'am. There are a couple of questions in the chat box. So Ritu asks, is jaw strengthening possible for adults?
Absolutely. At any age. I work with adults too, so I know.
And there was a question about anxiety around food. Why does it cause anxiety to kids? Why do they get anxious when they look at food?
Because of one, it could be ARFID, which is there, which is a psychological condition there where you see food, you're like, you're like that, right? And most again, why does it happen? I'll tell you, because probably some of your defense reflexes are still in place. That is what I have seen. When your primitive reflexes, your fear reflexes are still in place and holding on to that child, fear, anxiety, stress is a constant friend to them. Not a good friend, but a friend. And that's where we have to start. So, why the anxiety? Because there is hypersensitivity. They feel that this is too much information, I can't take it. So, the reflexes and the sensory processing are very closely interlinked. So, if the reflexes are still in place, it starts creating chaos with the sensory processing. And with that, it creates problems then later with functional activities like feeding. So for parents who are who have children who have extreme feeding issues, please look at assessing the primitive reflexes. This is a suggestion I have for all of you. And then how do you make food a friend? So that you lessen the anxiety around it. What can we do to play with food rather than eat it? Can they help you in the kitchen? Not eat it. Can they help you in the kitchen? Right? And things of the sort. That's how we kind of build up. It's not an overnight process. Feeding takes much longer. Some of them will pick up on it in a few months. Some of them take more than a year. It depends on how extensive it is for them. Yeah.
Aparna, do you want to ask?
Yes, Aparna.
You had mentioned sensory and perceptual processing. So I just want a clarification. When you say perceptual, you're talking about visual.
All of your senses. So one is that we're getting input. The other is, how do I use that input? Do I use it here like this? Do I use it like this? Another way, like I have to perceive how to use that information and do something functional with it.
Okay.
Right? So it could be visual, it could be kinesthetic, it could be any of the senses that you're using, but how do I use it the right way?
Right way. Okay. Okay.
Madhumita, you had a question?
Yes. Thanks, Shereen, for explaining it wonderfully. I have a question particularly about hierarchy that you mentioned.
I'm sorry, I can't hear you. I'm sorry, you're very unclear. Can you tell me again? Because it's very soft.
Just a minute. How about now? Do you hear me okay?
Much better, yes.
Okay. You mentioned about the hierarchy in working on various parts of the mouth towards feeding and then speech. Is there a particular order that we need to follow when working on, say, first the child needs to get worked on the lip strengthening and then the jaw strengthening and then lips and then tongue. So
Yep.
is there a particular in the talk tool that you mentioned, there are different hierarchies sets saying horn hierarchy, straw hierarchy. and all those things. Is there a particular order that we need to do this work with the child?
When you work with a child, you can do 5, 6 activities simultaneously. Okay, but because they're all building on common goals initially. So when you do oral placement therapy, they do have a structure, they do have a hierarchy. There's a very specific structure they have for you, and you learn that in your level 1 when you do it. So when you do, we work always on the jaw. So, but we can work on the jaw in multiple ways. We can use the chewy tubes to work on the jaw. We can use the bite blocks to work on the jaw. We can use blowing to work on the jaw, because you can't blow like this. You have to blow with your mouth jaw slightly open, keep it in that position, and then be able to blow. So you're still working on jaw stability at that time. So there is jaw work happening during blowing activities, whether whistle or bubble. There is jaw work happening when they're sucking from a straw. So 5 activities are all working on the foundation of the jaw, but at the same time, it is also building on lip movements and tongue movements. And that's the advantage of using these tools, because it is working on multiple goals with one tool. So when you're using a variety of them and you have 5, 6 activities happening together, because one tool will not help, never, ever, to make this program effective. You have to use a combination of movements to train the brain and the muscles to know what to do.
Got it. So it's pretty much we use different set of tools, and we are still working on dissociation and strengthening, but simultaneously on all the parts at the same time. Did I get it right?
Yeah. And then when you need to go, so that's the jaw work. So, but in OPT, there are activities specifically for lips. There are activities specifically for the tongue too, where you get into, but here it's not a gross movement anymore. Whereas initially it was more grosser movements you develop with the lip and the tongue. But now there are more fine control movements that you have to create. So there are other exercises, for example, holding an ice cream stick between your lips, and then we add coins, 1 rupee coins on either side, and we increase the weight. So it's like a dumbbell almost. And with that resistance, that they should be able to keep their lips closed, tighten their lips, not create compensatory patterns of taking the lip in and doing it, or flattening their lips, but getting the right movement and getting the strength. So there are other activities also to add on to get more finer motor control.
Okay. Another question is, my child is 14 years old. By the time which his jaw and mouth has been already formed or structured, maybe say my son has a narrow jaw or high palate kind of situation. With this condition, with the structural issues, is there a how successful can OPT be in helping him to feed properly and speak later?
You can definitely help him irrespective of the structure. So again, it depends on the structure, how much of the structure has changed, to see how much we can help. But those with high arch palate, the one that we would look at, the concern immediately that would come to me is the resonance, in terms of, are they nasalizing all the speech, or are they able to distinguish between the oral sounds and nasal sounds, because that will affect clarity, for example. But in terms of, can we get other functional movement? Yes, we can. We can work towards getting better functional move, because it's this functional movement we're looking at, right? So even though the structure is a certain way, we can look at using that structure, whatever it is, because you can't change the structure possibly now unless you're wearing braces or getting that dental work done, right? If you cannot change the structure, what is the maximum function that we can create in this, so that he has better feeding skills and better speech patterns?
Thank you. And one last question, being aware of the time. You mentioned about addressing the foundation of reflex integration. What is your primary recommendation of the reflex integration work that you see success with in order to achieve higher levels in the pyramid that you mentioned?
So when we work on reflexes, we look at identifying what reflexes the child has. We work on, there are many, many reflexes. We look at a basic 10 and look at, okay, do the children have these reflexes? And we look at, okay, how can we integrate them? Right? We use different approaches. I use rhythmic movement training. I use movement-based learning. I use a combination of whatever I've learned, and I kind of help the parents put it in place at home, because all the work is being done at home. Right. So that's how I go about it. And as we and reflex integration is not a 1 month, 2 month, or 3 month thing. Reflex integration takes 12 to 18 months, right? For the reflexes to really integrate properly, it takes. So you'll have to continue those movements, build on more complex movements, get into balance and coordinated movements, to work with the body, to work to the mouth.
Got it.
Yeah?
Yeah.
Okay. All right. Thank you for
And
the
Shereen, I had a question.
Yes, please go ahead.
Mamta. Yeah.
Yes, Mamta. Go ahead.
Shereen, my son is 23 years and I have been facing this problem for a number of years now. Immaculate eating habits. He chooses food very well, doesn't open his mouth, before taking the next mouthful, swallows very well. I have no issues with his eating. My only issue is that when he brushes, he almost flattens out a toothbrush in 2 days. So is it the pressure? Or how, is it supposed to be worked upon or what? Should I just let it be?
Again, it depends on how much is it affecting his life.
Okay.
If it's just the brush, but he's able to eat well, he's able to speak well. We look at the functionality.
For example, even when he's bathing, he likes to use the towel he presses the towel very hard on his body, so much so that sometimes he even bruises himself. So maybe that pressure is required in the mouth as well, I feel.
Possible.
Because,
so
anything
he's seeking
yeah,
proprioception.
he's sensory seeker. Yeah.
So he's
correct.
seeking proprioception, more pressure in his joints, or more tactile input. So again, it tells me that automatically there's something there. In terms of an imbalance in the brain, the imbalance in sensory processing that we need to work on, because those are core issues.
So what am I supposed to do at home? How am I supposed to
you can look at
help him out with that?
Again, you can look at increasing the sensory feedback he gets, but you can give him more proprioceptive feedback. There are a lot of stuff that you can do. Even if you just Google for proprioceptive activities, or trust me, Google will give you like 100 of them that you can do for teenagers too, or whatever age that they are. The same way, tactile feedback, we look at looking at, say, for example, brushing is one. Then we look at bringing in different textures, like a loofah instead of just soap with your hand.
Yeah, he does that for bathing.
Put to your body,
for
example. Right. So we increase the sensory processing ability by giving them more input.
Okay. So you mean to say something like joint compression, giving the brushing and the
joint compression? See, brushing is more tactile. Joint compression is more proprioceptive. Right. So you could have stretching, you could have compression, you can have both hands. These are some of the activities that we do. Sometimes we kind of stretch both hands together, say, "Ooh, let's stretch your hands." When we wake up from sleep, we like to do this for a reason, because it gives a proprioceptive feedback to our body, and that calms our body and regulates us to be able to get through the day. So sometimes if our children are not feeling enough, I would also ask you to check for reflexes if there are some still in place. I'm always going to go back to that. Sorry to be a broken record. I'm going to do that because I have seen the power of that and working on that. So checking for those, then looking at his sensory processing, then you will get better results. Just working on sensory without looking at if there's something underneath that sometimes doesn't get you the results, and your sensory processing goes up and down. I hope that made sense. Yeah.
Okay. Thank you.
All right. Sushma.
Hello, ma'am.
Hello.
Thank you for the information.
Most welcome.
Ma'am, as a parent, if we had to do oral placement therapy, should we do all the levels, or how can we find out which level should be opted?
So your level 1 has all the info. That is called 3-part treatment. That is the name of the basic course, 3-part treatment for speech clarity and feeding. That is your level 1, 2, 3. Now they keep changing it from when I finished it, so I don't know what that is, but 3-part treatment, that course. You can do it online. You can do it on their website. You can do it. You can just buy it and you have access for a whole year, so you can take it at your own pace. Or you can do it directly when they bring those courses. I know Jasmeet from Hi-Fi brings those courses. I know, I think Soj from Delhi also is bringing those courses in to India. So you could, look at doing those courses, that one course at least, because it gives you the whole idea. Now, if as a parent you're interested, say there's a course on feeding, okay, no, I think, I need more input on feeding, then go ahead. There are many, many courses on the Talk Tools website, right? Instead of trying to do all, I would say first start with 3-part treatment. Just see if that information that you heard today and that makes sense for you to be able to start something at home. That's my
doing that
suggestion
will
as a base.
doing that will help for speech in kids, ma'am. Like whatever you said, will we get all those exercises to work on our kid?
You'll get exercises, but you will not get how to translate it to speech. Okay, you will get exercises. You will get like what's the criteria, how much to do, da, 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 da. You'll have all of that, right? But how to translate it to speech is not there. They give you ideas like, okay, this can translate into, but the practical how to do it is not there as a level one, because a level one is just to give you an overall overview of what OPT is about. It gives you a lot
Can
of
we,
information.
like, ma'am, then can we opt to the other levels which help us for main exercises, which help us for speech or something like that?
So you can look at, there is a course on childhood apraxia of speech. There is a course on apraxia of speech. But before you do that, I would still suggest doing 3-part treatment, because it's all connected. 3-part is your base for anything that you do further. So do your 3-part and then maybe do a apraxia course, and you might be able to connect the dots better.
Ma'am, I have done primitive reflexes with Jasmeet, ma'am. Like brain optimization technique, and they have given all the reflexes activities. Will doing all those things, and if at all, if I take OPT with you or doing OPT as you said, level 1 course or something, will it help us more better? Because my son is 9 years and he's not non-verbal, non-speaking. He can't blend sounds, and like if I have to say amma, he says amma, mama, or appa. He doesn't listen to us, or the same thing. If I say appa, amma, he can't say amma at a stretch. Or if it is apple, he says apple.
So that's what I talked about, motor planning.
Yeah, motor planning.
So that's
So
where we
already
use cueing.
I started working reflexes since 2020. I used to do RMT, and then I started just with ma'am reflexes also. So can like still because of all those things only I got those sounds. Before he was not having even sounds.
Okay.
I got sounds now. Now it is few sounds still are backwards, but he only repeats after me. He doesn't say by himself. As you said, repeat speech without attempt from them is nothing important, because he has to say by himself. Now, ma'am, that is not there. So, what should I do to go further bit?
You can use tactile cueing, facial cueing to help him bring the words together rather than break it up. We don't want to encourage breaking up of words. We don't want to encourage that. We want to simultaneously stay with it. Okay, can you say with me? Let's say, bell. Can we slow it down, stretch it out, give them time to put it together? Then it becomes a word. Otherwise, they're just individual sounds. So that's the first thing that I would look at, is trying to see if you can combine by simultaneously saying it with them. If you want more practice, you would have to use play, repetitive play, or books that have repetitive words coming in if they enjoy books. Activities that require you to do this again and again in a fun way. Children will learn through fun. Children do not learn through sit down, you do what I want you to do, locking them up in a corner. None of that. Children don't learn through that. Right? So for you, I would say combining the level 1 OPT along with childhood apraxia of speech, along with facial cueing, will put all of them together. Because you mentioned those courses, so I'm just saying that it'll help you put it together.
Ma'am, one last doubt. Like if it is he can say ba, but he can't say be, boo, like in those things, be, boo, anything like he can say. Pa he can say, again he can't say pee, poo, like that. Will any specific thing I have to work on that?
So we sometimes use cueing. Either you can cue B, like giving the cue here, B, or go boo and give the cueing. Sometimes it works, sometimes it doesn't work. You could also use tools to help with the cueing process. For example, I'll show you. We can go into, say, B and give that cue that that's a E that you can get into to B, or we might use another tool, either a tactile tube or a bite block to help them understand to go to boo, 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 for example, to help them understand to transition with very concrete cues how to go to that next sound, because ba, pa, ma is very easy because I just have to drop my jaw, and that's why they get that faster. Right? But to help them transition, that's the motor planning that we have to get in with tactile cueing that you can do. Just an example.
Thank you.
Yeah.
Thank you. Yeah, ma'am. Thank you. Thank you. Thanks a lot.
Most welcome. Sangeeta, you had a question?
Yes, hi, ma'am. Can you hear me?
Yeah, I can hear you. Tell me.
Okay, ma'am. Actually, my question is mostly like Shushma. Here, we most of the autist and speech therapist. Uh, uh, I mean, they put the honey drop outside the mouth and they make them suck or lick that. And the parents are seeing that and doing that, that they actually they don't know what is right and what is wrong and what is going to be fruitful. They don't know. They just follow what they see. So,
Mhm.
is there any other inclusive training or something like that for the parents, as they are not professional? They actually not professional as parents. Do you have any that type of training? And another question I have, ma'am. My son, he is speaking when he is speaking, he is dropping the last sound, end sound of the syllable, like go, bad, not good, bad, ball, not ball. Every time he's dropping the last sound of every syllable. So
Mhm.
how can we support? How can I support them to make that sound? Uh,
Without missing it. Right. I get.
yes, yes.
With respect to your first question, yes, I do a lot of parent trainings. That's because I believe in parent empowerment. I believe that it's the parents that can create a lot of change at home. So
Okay.
I do a lot of parent trainings with in groups sometimes, and sometimes on individuals, sometimes in smaller groups. It depends what's feasible for the parent. So we go from reflex integration to brain balancing to OPT to communication, a lot of things that we kind of go across the board to help parents understand what they can do at home. So that is definitely already there. If their parents are a little bit more willing, they can also, like I said, do the OPT course so that they understand for themselves how you can take the exercises forward at home. It's not that you have the course and you understand everything. I mean, I started this in 2010. It took me a while to put the dots and like connect the dots and like, okay, this is how things are supposed to be. Sorry, noise from here. So, but again, it is a step that they can take if they want to. They can also do the course, and that's why I said it's open to parents. It's not just open to professionals. It's open to parents also who want to learn more on how to support their children. That's the first part. The second part of your question was how would you help your son? Would be to stress on the sound that he's missing out, but without adding a schwa or a to it. So if it's good night and if he's missing the dirt, say good, and to keep and stress on it so that that awareness comes that, oh, there is a sound here that's being missed out. And night, and stressing on that sound. And that will help him understand, oh, I'm missing something, and get him to encourage him to kind of finish it, add it in. But please do not add a ball to it.
But actually, ma'am, when we are doing that, you say hotella. He's saying that hotella, grando, like that, ma'am. That's the problem.
That's where you have to break those patterns because it is very easy to end with a vowel. Hey, if you're in South India, we can end
Yes.
with vowels because
Yes,
it's very easy to end with vowels in South India. All of languages here, we can end with vowels and we'll get away with it.
ma'am.
In other parts of India, you can't because there is a stop there.
Yes.
Right? And so you have to teach them the stop. And so when you stimulate it, you have to stimulate it the right way. Stop. And I have my hand coming up to give that indication of stop. We have to stop here. And that's the motor planning, like I said, initiating, maintaining, stopping. Also part of the process. It's also easy to go, Balla. Whatever. So if you say, good trying, I will never tell the child they are wrong. With whatever speech attempt they have, they will never be wrong. We just say, hey, can we try it this way instead? Can we say hotel? You know what I'm doing? I'm going to play around with that.
Okay.
Right, to help them understand, because I stretch it for a reason because it takes time to process what I'm doing and to
Right.
do a pattern. So that's why I stretch the sound. Hotel, stop, for example.
Okay, thank you so much. Ma'am, one more thing, one more request, ma'am. Can I have your PPT, please? That's very much informative. Can I have, please?
You will see it in the YouTube, but I'm not able to share the info. I'm sorry, but you can take it, all the info out of YouTube, because this is going to be put up on YouTube.
Okay, okay, okay. Thank you so much.
Right. Okay.
Last question.
Okay, last question. Mona Lisa.
Hello, good afternoon, ma'am.
Good afternoon.
Like I have a 5-year-old daughter. So
Mhm.
we started with OPT, and we had OPT for like 8 months. And then while working with her, we understood that she is having childhood apraxia. So, like while playing with her, like if I ask her to say go, and then we'll slide down the toys, then she, instead of saying go, she would either say po, go. Also, like whenever we used to ask her to say mama, she would, for all mama, dada, papa, I could see that she tried, but for everything she used to say baba, baba. So we learned that, like, we believe that she is having childhood apraxia, though we are not confirmed. And also, like, every time we ask her, she would be either yawning, or like she would be in lot of stress, like she's trying, but some other sounds come out. So what are your, like, what would you like to say about this, like what?
So the first thing I would say is check her reflexes, because I'm pretty sure there are some that are there that are interfering with this process of learning. I told you I'll be a broken record when I say these things, but it is because I've seen the result of the same. So please check for her reflexes and see if there are some mouth reflexes that are still present, some body reflexes that are still present, because hand reflexes, mouth reflexes, and feet reflexes will affect speech and language development.
I'm not very much sure, like I'm not clear with the reflexes, but yes, she has problem with the, like, the fine motor, like writing. She know, like she can write A to Z, but I have to, like the grip is very poor, and also, like, so uh, do
They're
you
all
believe that?
indications, what I'm saying. These are all indications that reflexes are still there.
Yes, like, do you believe like working on TLR and Palmer grass would help this, like, or?
Of course. Rooting reflex, suck reflex, Palmer-Grass reflex, Babinski reflex, ATNR, STNR, TLR, the fear reflexes, if you want me to name, I'll start naming all of them. Fear paralysis reflex, Moro reflex. These are all the ones that are in place. Working on just two will not help. You need to first find out what is there. That is very
Yes.
important. Please find out what is there. Once you find out what is there, then you start working on them. Then we put a goal, a priority. Okay, what? Because we cannot always jump to speech as the priority. Please look at the whole child. If anxiety is a big one, work on anxiety first. Then speech, it'll be easier for speech to come in. If
Yes.
anxiety is always in place, I'm always wrong, I can't get it, I don't want to do this, I'm running away. Fight flight response is triggered each time. So now that's why when children hear that I'm a speech therapist, they're running towards the door. Fight flight response has been triggered. Oh no, speech has come. Right? And that's because there is something there that anxiety is triggering it. So we have to work then on the anxiety first. I'm not saying it cannot happen in parallel, but I'm saying please understand that that is a base, a foundation for which we can build the other integration processes in.
Yes. So, like, for me, like, we stay at a very, like a we don't, like a small place where, like, we don't have very good therapy centers, and we had been working online sessions from the therapist. So do you believe that this working online would help us uh, overcome that anxiety fear? Because whenever we take her to uh, though she is very much comfortable in schools and everything, but whenever we used to take her for assessment with therapist, she is little reluctant because she had been working with me since a long time. So do you believe these online sessions would help to overcome this anxiety fear? Because working,
You're
yes.
talking to somebody who does all her work online. So it's, I mean, for me, yes, online does work. There is always a difference when you work back, I mean, directly with the child. There is definitely a difference. But if the child is more comfortable with the parent, I prefer to empower the parent to know what to do at home. What could you do at home to help this process get faster? It doesn't mean that they have to love me and do all the work with me initially. If they're willing to do it with a parent, brilliant. Let's start the process off. And as the anxiety comes down, you'll see that they're willing to work with different people. Now, I don't work with the children directly online. I work with the parents online. Right. So that means you get empowered to know what to do at home. So that kind of work I agree with. When you have children come online, then there's a stress. Oh God, I have to perform. I have to do this. Who is this person in front of me? So many things coming. Right. And that creates more anxiety for the children. So I don't believe in working with children completely online unless they slowly get used to me. Like I do music and movement groups online because that's got music in and that's fun. And okay, then we can create some kind of fun factor in there and they might be more willing to do things with me. But if you say speech therapy, say do this, do that, not happening. We will do it separately with the parent by teaching the parent how to do it. That's what I believe in anyway. I'm not saying that's the only way. Yeah.
Okay. Got it. Got it. Thank you so much.
Most welcome. I've really got to stop now because I have another class in some time.
Thank you so much, ma'am. Thank you so much, Shereen, ma'am. Thank you everyone for joining.
And if any of you had more questions, please reach out. You can ask Bindu for more help in that. You can reach out anytime. I have no problem. Just because right now I have a class to get into. So thank you so much for all of you for coming and for asking your questions. I always love answering questions if I know the answers for the same. And if I don't know, I will always go back and find out. So do reach out if you need any more support or help. And I'm wishing you all the best. Thank you, Bindu, for arranging this.
Thank you, ma'am. Thank you so much.
Thank you.
Take care,
Thank
everybody. Bye-bye.
Thank you, Bindu.